Presentation of myocardial infarction. The problem is we are discussing about pharmacoinvasive therapy, the effectiveness of thrombolytic agent. If you see the initial 3 hours, it is as good as primary PCI. But more you delay, lower is the efficacy of this thrombolytic therapy as well. So if someone presents to you after 12 hours, then there is hardly any role of thrombolytic therapy. It is mostly intervention. So good number of patients, they present to us very late. And as we all know why this heart attack happens, it is due to erosion of the plaque. And if you see the sudden cardiac death, almost 1/3 of the sudden cardiac death in autopsy study, it was found due to heart attack, and one of the coronary artery was totally occluded. So this is a very significant health situation, and this heart attack may even occur in lesion which are actually less than 50%. So there is the role of vulnerable plaque. We are discussing about how to detect the vulnerable plaque. So the amount and duration of coronary thrombus play an essential role to determine the prognosis of ACS patient. We say that probably thrombus and calcium, they are the two greatest enemy of the intervention cardiologist. But for calcium, I was listening to my previous speakers, it is very important, but the problem with calcium, you can actually plan. You can have your tools ready. But as more and more interventional cardiologists are doing primary angioplasty, and we expect more junior people will do primary angioplasty, so they should be very much prepared beforehand to tackle the thrombus. So coronary thrombus has a crucial impact on the percutaneous coronary intervention performance and outcome, and it is a strong predictor of the PCI outcome as well. So this is how we grade the thrombus. We know from grade 0 there is hardly any visible thrombus. Then we had grade 5, which is totally occluded. So in between, we do have different other grades. So let us start with a case where we can see a grade 4 thrombus. So late presentation, more than 12-hour ongoing chest pain. Yes, we took him for angioplasty, and we can see grade 4 thrombus. What does it mean? More than 2 times of the vessel diameter. If the thrombus diameter is more than 2 times, this is called grade 4. So how do you approach? So though the thrombus aspiration is now routine thrombus aspiration is class 3, but I know in many parts like our India, we do thrombus aspiration. And similarly in this patient also, we went ahead with thrombus aspiration. We can see the thrombus burden has significantly come down. Then we deployed a stent and we get a very good result. So good for this patient. But all the patients are not same. Say for example, another patient, this was done by one of my very close colleague. You can see the huge thrombus. He was taken for primary angioplasty within 12 hours, but you get sometime this kind of huge thrombus. What do you do? So he actually planned for thrombus aspiration with the usual catheter. In our lab, we have eliminate catheter. But had it been my case, I probably would have planned in different way. But see what happens. After repeated aspiration, a significant thrombus burden is still remaining. So he thought, let us trap the thrombus with a big stent. So it went ahead and deployed the stent, and you can see a significant thrombus inside the stent. It's not a good thing to happen because this will increase the chance of stent thrombosis. So visible thrombus after stent deployment is an indication, though it's not a class 1 indication, it's a class 2 indication to do repeat thrombus aspiration. So repeat thrombus aspiration was done, but the final result, you can see it is not very good. So some of the time, you may not get an optimal result. So let us see what are the options in thrombus aspiration. We do have 4 options. Manual aspiration catheter, which most of us are doing. Then we have power source thrombectomy. I'll show you a few of my experience. Ultrasound-induced sonication, I don't have any real-time experience. Embolic protection, mostly we are using in saphenous graft and carotid angioplasty. Primary angioplasty, there are some evidence, probably it will reduce the distal embolization, but we are not actually using them. So thrombus aspiration, what is the evidence? Older trial like Tapas trial, it showed encouragement, so it was there in the guideline, but more newer trial, TEST and TOTAL, they actually showed it is actually not improving the outcome of the patient. So current guideline, it is not a routine indication. So routine we are not supposed to do, but as I mentioned, after stent deployment, if you can see visible thrombus or very high grade thrombus volume, you can still do it. So this is a new device which we are having. Now last time in Dhaka Live, I showed intervention in pulmonary embolism. The same system, it is called Indigo system, and the name of the device is Penumbra device. So this is a vacuum system, computer-assisted vacuum system. The catheter which is used for pulmonary intervention is CAT-8 catheter. Now they did some modification. They came up with CAT-RX catheter, which is actually dedicated for coronary intervention. So I'll show you a few case examples. This is one of such cases where I use CAT-RX Indigo system. We can see late presentation more than 12 hours, almost some collateral starts developing, PDA PLV is spilling, but we can understand proximal to distal RCA totally, laden with thrombus. So we took this device. This is a device where you can see the French size is higher. So after initial use, we could see the artery. It's a big artery. Then we did repeated aspiration. You can actually aspirate larger amount of thrombus, older, more, delayed thrombus you can accept. Then you can see the, vessel. Now the lesion is seen, but yes, there is some distal embolization of thrombus. This catheter is so easily negotiable. You can take it to the very distality of the vessel. And thus, after repeated aspiration, you can see how nicely the vessel looks. Now we went ahead, deployed the stent, and this is how ideally you are supposed to deploy the stent. You should deploy it very slowly so that both the end of the stent is inflated so that you can actually trap the thrombus in between. But even after deployment of the stent, you can see the stent is not well deployed. There is some underexpansion, and again there is some distal embolization of the thrombus. So we again took that, same catheter after post dilatation of the stent. We took the same CAT-RX catheter. It is very negotiable, and after repeated aspiration, you can get this kind of fantastic result. So another case example with this CAT-RX Indigo system, you can see the RCA is very bad. There is a Shepherd-Cook in the proximal and the ectatic segment and huge thrombus burden. So we took the catheter RX system, removed whatever the thrombus which was available. Then we can see there is a discrepancy in the size of the mid and distal RCA. Generally in primary PCI, we do not suggest to use IVAS catheter, but in this case we use to see the distal reference diameter of the vessel. And we saw that it is almost 3 millimeters. So we deployed a stent which is 3 millimeter, and this was the end result. I'm sure without using this type of catheter, probably this kind of result could not be possible. Now always is it effective mechanical aspiration? Sometimes it also fails. Like this case, after repeated aspiration, huge 5 millimeter RCA vessel, we could not achieve good flow. So there is an alternative strategy known as intracoronary thrombolytic therapy. We are discussing about pharmacoinvasive, but there is evidence with half dose tenecteplase you can actually deploy. And you can see in this case, after deployment of tenecteplase inside the coronary, huge thrombus is seen, and we can see the huge RCA distal vessel, PLV and PDA. And we did a check angio next day. You'll be surprised to see this was the result, and actually did not even stent because it required a more than 5 millimeter stent for this case. And the result is optimal, and patient is doing good for last 1 year. So you should actually individualize the therapy. There is good amount of evidence of intracoronary thrombolysis with half-dose tenecteplase. Many of the trials, they have used this kind of catheter, AMI catheter, but for your case, you can actually use the aspiration catheter to deliver the thrombolytic agent. Now, again, another case, we are discussing about pharmacoinvasive. This is such pharmacoinvasive. We can see proximal LAD is ectatic, huge amount of thrombus. So what we did, we just made a passage for the stent and trapped the thrombus. And you can see the final result, which is very optimal. So all the cases are different, and you should plan accordingly. Thrombus is not same for all the patients. And this is the last case which I would like to show. This is a case where angioplasty was done 15 long years back. He presented with very late stent thrombosis. So after 15 years, inferior MI with 2:1 block, we actually did thrombus aspiration. We could see huge thrombus burden, but more importantly, the previous stent probably was not well deployed. So we did IVAS. You can see the vessel reference diameter is 5 millimeter. The stent is only 3 millimeter, which was used. So what we did pre-dilatation even in primary situation with OP and NC balloon. You can see 2 wires, and we went up to 45 atmosphere. We actually broke the previous stent, deployed another stent, and this was the final result. So you should actually individualize the therapy. Thrombus and calcium, as I mentioned, are the 2 greatest enemies of intervention cardiologists. Though current guidelines do not recommend routine use of thrombus aspiration in STEMI patient, high-grade thrombus burden or visible thrombus post-stent deployment is an indication, though not class 1, it's a class 2. Newer technologies such as Indigo system-based penumbra vacuum thrombus aspiration using CAT-RX catheter is extremely important if you have the device. It costs around 2.5 lakh extra in our country. It can be very useful in some of the situation. Intracoronary half-dose thrombolysis could be a good bailout in difficult subset of patient, and it's very important to individualize every case and have separate strategy for all of them. Thank you very much.
Thank you, Arindam. Excellent talk as usual.